we started something called the Frailty Partnership in 2018, which was a group of providers supported by the CCG who came together to look at developing a frailty strategy for the city. And generally the attendance was service managers and clinicians from across the whole spectrum of providers in the city. So third sector, the mental health trust, the community trusts, the hospital, the council services, general practice, and as I said, the CCG. So after several months of talking together, we developed a strategy and presented that to the CCG, who felt it was a good strategy and were willing to fund parts of it. And so they gave us £5 million over 3 years, which is when we had to form a bit more formal governance to manage the money amongst ourselves. And that led to the development of the Frailty Board. So we had the wider partnership, which was all comers welcome, deep discussions about theory and strategy for frailty, and then a smaller board that looked at managing the money and the projects that came out of it. And we use the partnership to develop relationships and ideas and develop clinical strategy, and the board to look after money, targets, outcomes, and the more formal governance. The two go hand in hand, but they're non-divisible. Neither would work without the other, really. When we first came together as a group of individual providers, we all spoke a completely different language. So in health, we talked about patients and pathways. In the council, they talk about people and need. In the third sector, they talk about the whole person and families. And we in the medical world, we use the word frailty and clinicians, and in other providers, what does frailty mean? What does clinicians mean? So we spent the first 6 months coming to a collective view of what the problem was, who we were working with, and what we would call stuff. And though that sounds very basic, it's fundamental to working together. So I think the first real benefit we have from the partnership working is understanding each other. And then from that understanding grew the ability to create a strategy. We've always had good attendance from across a range of services. And I think that's because, the topic's really important. It's a major part of what all the services do. But also it's really good to get in a room with people from different backgrounds. It brings a completely different perspective. The conversations you have are different and interesting, and you're always finding out something, because across all of those services that come to the partnership and attend the board, the individuals represent several thousand workers, supporting upwards of 90,000 people within our population group. So that's a huge wealth of energy and experience, and so you get into conversations around what people are doing. And I think from an organizational perspective, it allows you to create networks and connections, and then from the person that we're looking after's benefit or supporting, then those connections mean that the people you're seeing are connected to a wider set of resources. And so, we're always trying to push for better joined up working, which creates a better experience for the user and better outcomes. We've done projects. So obviously you've got people who attend the partnership and the board, and that's, might be a cast of 50 or 60 people, but at times, we've done projects that bring a much wider group together. So in the population health management national pilot that we did a couple of years ago, that involved bringing all the local care partnerships together to do a project where we use data to look at populations and selected groups of people for interventions, and then worked as a team, so a multi-agency team to support those individuals. A lot of people bought care coordinators or trialed care coordinators to support patients. We use data to select who might be best placed to benefit from those interventions. And so we sort of, the process that we went through to form the partnership and the board then happened at the 13 local care partnerships across the city. So we brought lots of people together who worked locally in those patches, who had never met each other before, to talk about people living with frailty and how best to support them, and data. And again, you went from that position of what's in it for our organisation to, gosh, there's a lot going on in our communities, and how do we link up and support people? So, and those relationships have lasted, and the local care partnerships continue to work together. And there's changes to the contracts that's happening for some of the health providers that are going to put a new purpose and energy into those partnerships as well. So that's called the anticipatory care work that we're going to do over the next couple of years. There's trusting the process, but there's also being canny about the politics and having to take advantage of the background stuff that can either derail you or you can say, well, that problem could actually be turned into an advantage, and we'll work with that and trust to the fact that if you work with it, it'll come good in the end. So there's been a lot of really good people in the partnership and on the board and in the local care partnerships that have, without certain individuals, your projects don't go anywhere. They don't get off the ground. They're really reliant on people who are passionate and have got energy and drive. And thankfully, there's always people in every organisation I've found that come forward and make things work. And so you're making sure you find those people and helping them to shine is a real, another thing that you need to do, and making sure that then you've got support from people with regards to funding and governance, and that's part of the trust of letting it all come together. Because if you've got the right strategy, the right ideas, lots of energy from clinicians who want to do stuff and service managers who want to support that, then I've found that generally it comes good. And I guess some advice to myself would be to trust to that, because it'd be a lot less worry for you over the course of the programme. But the board was, as part of the test bed for the new integrated care partnership governance in Leeds, we were given responsibility for allocating a new pot of money, which was £4 million recurrent coming into the city against something called Ageing Well. And that money was to be spent on looking after people when they were poorly, to try and stop them from going into hospital or to get them out of hospital. And we were spending that money on our new virtual ward for frailty, and that had been surviving on non-recurrent funding. So we're trying to get that into a recurrent funding position. And we initially used the traditional way of commissioning, which was ask providers to submit their bids and then have a look at all of those bids on their merit and decide which ones we're going to fund. That resulted in more bids, all with equal merit, exceeding the pot that we had. And the providers around the board didn't feel at all comfortable in saying that other providers should or shouldn't have the money, and they should. So that resulted in had to keep going back to that decision, and people couldn't make the decision. So in the end, we changed the approach, which was to bring all of those bids together into one bid, and still try and deliver all the functions that all the separate bids did, but make it fit the pot, which has resulted in a new provider collaborative. And that allowed us to get the decisions passed. So the process of having to allocate the money then resulted in a different set of relationships and approach to achieving an outcome, which took a long time and some difficult conversations, but I think in the end put us in a much better place.